So I'm very excited about the work of this committee and just the fact that this committee exists, and especially happy to have been invited to participate in a small way. So thank you. So my overall interest is in creating sustainable interventions that support development of young children in primary care settings, in pediatric primary care settings. So what I'm going to do today is to describe one such intervention that we carried out in Massachusetts in a number of practices with the help of an NIMH R01, which was parent training groups. I have to just figure out, okay. So in general, pediatricians provide a lot of reassurance and support, screening, prevention, anticipatory guidance. They do a lot. But they rarely do any real intervention. So we know, oh, sorry, this was, okay. We know that disruptive behavior in toddlers is common and results in a great deal of distress and risk. We know that toddlers with early disruptive behavior are at risk for developing ODD and ADHD later in childhood, and we can actually predict which ones those will be. We know that those children can be identified early and that those behaviors are responsive to changes in parenting. So we created an intervention, sorry, my slides got a little bit out of order here. So we created an intervention in a network of primary care pediatric offices in the Boston area that we called Advanced Parenting Education in Pediatrics. We called it Advanced Parenting Education because we wanted to acknowledge the fact that parents are already pretty expert in what they're doing. The pediatricians actually really liked that name, the pediatricians we were working with. Sorry. So there's ample evidence, and you've already heard this morning a lot of that evidence, that parenting groups are effective in reducing disruptive behavior in school-age children, and that they are effective also in reducing the incidence of abuse. Actually, I heard, before I do that, I actually heard that there's yet another article in the American Journal of Psychiatry this month pointing out the effectiveness of parent training in preventing antisocial personality disorder. So there's plenty of evidence to lean on. What we did not know is if this effectiveness could be extended to toddlers, nor how this type of an intervention would work in a pediatric setting. On the other hand, pediatrics seems like, and Margot has just said this as well, like an ideal setting to implement this kind of an intervention because pediatricians see children and families frequently and have a long-term supportive relationship with them. They focus on prevention in general, and the pediatric office is accessible and not stigmatizing and indeed inviting. So we had funding from NIMH to work with a network of 11 practices in the greater Boston area. We developed a screening checklist specific to this project. To do this, we used the longitudinal data that had been obtained in the development of the ITSE, the Infant Toddler Social Emotional Assessment Scale. What we were able to do is to look at the data of 6-year-olds, identify those children who had a diagnosis of oppositional defiant disorder or attention deficit disorder, and then look back at the symptoms that those parents had endorsed when the children were 2 and 3. So this checklist, while it's completely idiosyncratic, was empirically supported in that way. The parents who endorsed those symptoms were eligible for a parent education group that would take place, that was advertised to them, that it would take place in the pediatrician's practice setting. So we modified the Incredible Years curriculum that you heard about this morning and that many of you use and know to deliver it in 10 sessions. We encouraged both parents to attend and we served them a light dinner. We wanted to ensure that the project would outlast the grant. So we trained 2 staff members in each office to administer this IY intervention alongside the psychologist who was a part of the research staff. We did not provide either child care or transportation. Those were decisions that we labored over, and both before and after this project. I'll say more about them later. The research protocol was a classical randomized control trial using a waiting list as a control. We ran into two real-world logistical problems that I'd rather not tell you about because they complicate the interpretation, but they were what happened in the real world and would happen under other circumstances as well. First, in the smaller practices, it took longer than we had anticipated to assemble a group of 20 to 24 parents that we needed to be able to randomize into an immediate intervention and a delayed intervention. So because of the design of the study, we had to have at least 20 parents who had agreed to do this, and we didn't think we could make them wait more than a month after they had agreed to participate before the so-called immediate parent training group was to happen. So as a result of that, let me see here. Yeah, so as a result of that, we had to forego the waiting list in those cases. So we ended up with a third non-randomized parent training group, so without a wait list control. The second problem was that once we had assembled a group of parents and we were all set to go, almost inevitably, one or two sets of parents couldn't come on the night that all the other parents could come. So, you know, Tuesday night was what everybody else agreed to, but one set of parents couldn't come or two sets of parents couldn't come. So what we did under those circumstances, which happened frequently, was to randomly select parents out of the wait list group, put them into the immediate intervention group. As a result of that, you'll see in a second that the numbers we have in the immediate intervention group are greater than the number in the control group. So just to run through quickly what we have here. So of the eligible parents, only 41% agreed to enroll. We have pretty good reason to believe that this relatively low enrollment rate was due in large part to a rather burdensome research demand. The sample was quite diverse, with 26% minority race ethnicity, 34% with a high school education or less, and 26% with a family income of less than $20,000. All the parents had children between their second and fourth birthday by design, because the screening test was given at the 2- and 3-year-old well-child visit. So by definition, the children were between their second and fourth birthdays. 2/3 of them were boys, as one might expect. And we ended up, as I mentioned before, we ended up with 89 parents in the immediate parent training group, 61 in the control group, and 123 in the non-randomized parent control group, parent training group. We used the ECBI, the Early Childhood Behavior Inventory, and the parenting scale as our primary outcomes, and we also did a structured observation of parent-child interaction. So we did these assessments immediately before the intervention, immediately after the intervention, 6 months later, and 12 months later. And coders were unaware of both the group and the time in the assessment process. Analyses used an intent to treat model, which is fairly conservative because you can see that some number of parents didn't come at all, and 20% of parents came to minimal numbers of sessions. So I guess that's all. So I'm going to run through the main results. Looking first at the ECBI problem scale, the dashed lines that I have up here now represent the waitlist group. This solid line represents the immediate intervention group, and this middle line represents the non-randomized intervention group. And those, I'm going to run through a bunch of slides, but those symbols all remain. So for the ECBI, there were no significant differences at the pretest. There was no significant change in the wait list. There was a significant change in both of the parent training group interventions, a significant time by condition interaction at the post-test time in both of the parent training group conditions, which remained at 1 year after the end of the intervention. Very similar results from the parenting scale. No significant differences at pretest, no significant change in the wait list, significant change in both of the parent training group conditions, significant time by condition interaction at the post-test for both of the parent training group conditions, and that interaction was still significant at 1 year. It's a little more complicated when we look at the videotaped observations. Again, there was no significant difference at pre-test. There was a significant change in both of the parent training group conditions. There was a significant time by condition interaction immediately at the end of the intervention. But because there was a significant change in the wait list group as well, the interaction was not significant at 1 year after the end of the intervention. We got very enthusiastic feedback from both parents, from both parents and pediatricians. The parents said things like, "This group has changed my life. I deal with my children totally differently now." And almost all parents wanted the groups to continue at the end of the 10 weeks. Pediatricians also said things like, "These parenting groups have been such a benefit to our practice. I wish they could be a regular part of what we offer." So in summary, we delivered an evidence-based parent training group to a large and diverse sample of parents in 11 pediatric practices. Inclusion was based on a screening test, so this was secondary or indicated prevention. We trained practice staff to co-lead the groups, and we offered parenting groups in pediatric practices using an evidence-based protocol. We documented improvement in child and parent behavior 1 year after the intervention. So I was told to say something about costs. So what I'm going to show you now is sort of a summary of the cost question, but I have a lot more details if people want to see more. But in summary, the startup costs a lot. That's, I guess, the sort of the main point here, is that it's to do it right, to buy the appropriate materials, and we're assuming, when I say the appropriate materials, we bought for each of the practices the toddler and the preschool materials, Incredible Years materials. So to do all of that and to train 2 leaders from among the practice staff is close to $10,000. But once that's done, and apologies to Carolyn on this, but once that's done, if you really cut corners and kind of institute a no-frills version of a parent training group with only 10 sessions, that could only cost $265 for 10 sessions, so $26.50. Not even, not a whole lot more than a copay. So it's not really very expensive. Now, if you do it right, and you add food and the book that we gave to each of the parents, and most importantly, childcare, the cost goes up considerably. So again, I have details of this if people want to talk more about costs, but I'm going to skip them for now. So it is feasible to run parenting groups in pediatric practices. Parents are happy, pediatricians are happy. Space was not a problem. We expected space to be a problem, but it really wasn't. And pediatric staff with some mental health background or nursing background and specific training, Incredible Years training, can run the groups with fidelity. To do this requires a practice that's fairly large and or includes a wide age range. So our groups, as I mentioned, the children were between their 2nd and 4th birthday, but because of the problem I mentioned in terms of filling the groups, we recommended to the parents, or I'm sorry, to the pediatricians as we were finishing up the project, that they actually run the groups up to the 6th birthday, just because they could find enough parents that way. Most practices are not that big that they would have enough parents to fill a group in a timely fashion. Our impression is that a group that included children from 2 to 6 would work just fine in a pediatric practice. But actually, I'd be interested in Carolyn's thought about that. That's not standard Incredible Years policy. But again, this really replicates findings that we know from when these groups were done with older children and are done in mental health settings, but what's unique about this is the pediatric setting and the fact that we did it with younger children. And again, the cost is modest after startup, but we really had difficulty finding a way to get these paid for. So I'm going to, let's see, I'm going to diverge a little bit from talking about that program to say that pediatricians are really not used to doing interventions in their practices, but I think there's some small things that could help pediatricians learn to do more intervention, especially preventive mental health intervention. First of all, some kind of a system for routine screening is necessary to identify developmental and behavioral problems early. And we've learned this pretty recently in Massachusetts, because since 2008 we've had universal behavioral screening at every pediatric well-child visit, which is seemed like a kind of daunting task initially, but it's actually worked. So we need to develop some sort of screening system. And secondly, pediatricians are going to have to be encouraged to work in teams, to include a mental health clinician as a partner in practice. That's, so at another time, I would love to describe in more detail the screening instrument we've developed, but I can't help myself. I'm going to show you one slide about the screening instrument that we've developed, which I think would actually make some of these interventions more palatable in pediatric care. So we call it the Survey of Well-Being of Young Children. It's a very short parent report checklist tagged to the pediatric visit schedule. So therefore it's easy to include it as a regular part of well-child care. It's free and in the public domain, and it integrates cognitive, language, motor, social, emotional development in one instrument. It includes also screening, a brief screener for autism, for parental depression, and includes a number of other family risk factors. So we're in the process of creating an electronic platform for this, and we are talking with some of the EHR developers about including it in electronic records, which of course would open up all kinds of opportunities. So I invite you to look at the website. With regard to the other point, co-located mental health care is kind of become relatively commonly discussed within internal medicine and family medicine, but it really hasn't made it into pediatric practices yet. But having some kind of a child development or mental health clinician in a pediatric practice has pretty obvious, intuitive, and documented benefits, and would allow for interventions like Incredible Years or a number of other kinds of interventions to be much more well, integrated, for want of a better word, or could happen more automatically in a pediatric practice than it currently does. It's clear from the data that do exist, and they're slim for pediatrics, but it's still clear that parents and children do benefit from the easier and more comfortable access to care that pediatrics provides, and having the integration of medical and mental health attention. So there's actually an article in Pediatrics this month, which I just got yesterday, that is yet another demonstration of the effectiveness and the enthusiasm with which parents sign on to that kind of integrated care. So having such a person in a practice would make some of the training costs and some of the implementation costs of something like an Incredible Years program much simpler to incorporate. So actually I was also thinking this morning during Lauren's talk that this having a mental health person in the pediatric practice would also create some demand. It would, it would make both parents and pediatricians be thinking more about which parents they should recommend to come to a parent training group, and making it easy for that to happen. I think we don't know that. So I really think that we know what to do. We just aren't really sure exactly what the strategy is, or nor do we quite have the political will. But thank you.